So this is a very important case. This is when you have to recognise, have a good look at this case. So we've got a 19-year-old patient. There's definitely a lesion there. Try and decide aggressive or not. It doesn't look like the case of fibrous dysplasia that I showed you that was non-aggressive. You can't draw around the edge of it, but it hasn't produced a periosteal reaction. But look at the matrix, it's produced bone. So anything that produces bone is bad news. So remember that case that I showed you right at the start, the prostate metastasis, sclerotic produced bone, mixed lytic. So this has produced bone. So this is the matrix you would say for this is osteoid or bone formation. So there are two really horrible primary sarcomas in young patients. We've seen Ewing's sarcoma. Neuroblastoma doesn't look like this, and it's much younger children. We're talking about 4, 5, up to 10. So this is old adolescent, young adult osteosarcoma. So this is a tumour from the bone that forms bone. So this is osteosarcoma. So for me, this is nothing but osteosarcoma. But when I've shown other people, trainees and some of your previous colleagues this case, some people have thought it was benign because it doesn't have any typical periosteal reaction. But basically anything that forms bone is definitely not benign. It's definitely a tumour. This is really bad news as well. This is bad news. So this patient has imaging of the whole bone. So they'd definitely have an X-ray of the whole bone. They'd have an MRI of the whole bone. They'd have a chest CT, and they would have staging of the whole skeleton, so bone scan or MRI scan of the whole body. This is osteosarcoma. This is I don't like the phrase Ant Mini, this is a spot diagnosis. This patient, of course, will have a biopsy to prove it, but doesn't need a biopsy to make the diagnosis. This and Ewing's are very, very classical. These, you don't have to biopsy it to be very confident as to what you're dealing with. So I showed you that case of osteopoikilosis. You can get sclerosing bone dysplasias that can give you strange appearances to the bone, but you really should not call it that because you'd want to see more of the skeleton. This is osteosarcoma until proven otherwise. So the treatment for this is chemotherapy and surgery. The patient's going to have the whole of their femur excised and replaced with metal. This is nice. The thing that you need to see all of the bone to understand what's going on here. So this patient needs an X-ray of the whole humerus. It's difficult to say, isn't it, precisely what this is, because you need to see the whole bone. So this is one of those that doesn't really obey all the rules. You could say you could draw around it. There's no pathological fracture. There's no periosteal reaction. The bone is expanded. It looks very strange. Have you heard of the term ground glass matrix? Yeah, it's one of these terms that means nothing to anyone really, but people use it all the time. This is that so-called ground glass matrix. I didn't even really know what ground glass was, but it's, you know, in old chemistry bottles, you know, the kind of top of it, that's ground glass. It's not a useful thing to correlate it with, but this is a ground glass matrix, and that is a fairly typical description of fibrous dysplasia. Does it look anything like that patient with prostate cancer and the tibial lesion? It does a bit. Fibrous dysplasias, it's as it says, it's a bone dysplasia, and it's where the normal bone is replaced by fibrous material. So it can give you this disorganized pattern, but it's essentially elements of the normal bone that haven't formed properly. So it can look like normal bone, but the bone is expanded and looks very strange. It's common in the upper limbs. It's the commonest rib lesion as well. So actually, yeah, this helps you with the diagnosis. The ribs are abnormal as well. Can people see? The ribs are all abnormal. So the more you look, they call it search satisfaction, don't they? You see one lesion, you stop looking. Have to keep on looking. It's like the arthritis as well. If you find one erosion, look for any more that can help you with what it is. So the fact that there are multiple lesions may or may not help you. If you think it's metastasis, that's going to seal it for you because you're going to say, oh, there's multiple lesions, this is metastasis. And I don't think you'd be wrong to say it could be metastasis. You'd want to see it all. To have this many lesions, the patient's going to have a known syndrome. Have you heard of McCune-Albright syndrome? that's a syndrome that gives you fibrous dysplasia and other endocrine disorders. So this patient is almost certainly going to have that disorder. You can get isolated a small area of fibrous dysplasia just as a one-off, but if you have so much involvement as this, it's most likely to be this McCune-Albright syndrome. So I put this in next to it because this at first glance looks similar to that humerus that we've just seen. But when you look a bit more closely at this lesion, there are some features that show you it's different and it's not the same. And the most helpful bit is this. It's a bit small, but this is the most helpful part. So, you know, I was talking about how if you get discontinuity of the bone, you have to explain why it's discontinuous. It's because something, namely tumour, has taken it away. So this is what we're seeing here. So if the bone's discontinuous at any part, just think, could it be tumour? The other main mimic of fibrous dysplasia is a big cartilage tumour, and that's what this is. So this is a ginormous cartilage tumour or a chondrosarcoma. So you can tell that it's an aggressive tumour because as soon as any tumour starts to break outside the bone, then it's aggressive. So that's what we see here. The tumour's starting to come outside of the bone, and as soon as it does that, then it's kind of game over. The tumour wins. So this started out as a cartilage tumour or an enchondroma, and it's eaten out of the bone. These are really difficult management cases. So I remember this patient. He had this lesion, we watched it grow, and he didn't want any surgery, understandably, because it's major surgery to take out the whole of your humerus. It's going to leave you with a big functional deficit. But you're gambling with, well, is it going to become malignant and actually kill you in the end? So this patient gambled and lost. He decided he didn't want surgery. And then this follow-up image showed it broken out of the bone, and his chest CT showed he had lung metastases. And by that time, there's basically no point in taking out the humerus if it's already metastasized. And these tumours aren't responsive to chemotherapy, so bad news. There is an argument still for performing the surgery on his arm, because if you don't, the tumour's just going to grow and grow and grow and grow, and then it's going to start to fungate. So he probably does still warrant the surgery, but it's not curative. These are now spot diagnoses. These are nice. Now we're looking at cartilage lesions. These are lovely. This patient's probably got a syndrome as well. Anyone seen these before? These are really common, yeah. These are osteochondromas. So the hallmark of an so they don't fit into that nice category of bone tumours that we talked about before, but these have kind of got their own classification. The hallmark of an osteochondroma is, people call them exostoses. That's just a generic term that doesn't really mean anything, to mean something protruding from the bone. You can always classify an exostosis and say what it actually is. So the hallmark feature of an osteochondroma is that the medullary bone continues into it. So can you see here it's lined by cortex and the medullary bone goes into it. So these are multiple osteochondromata. And these have cartilage sat on top of them. The textbooks always talk about cartilage of 1 centimetre thickness and more equals malignant degeneration. So these can also kill you as well, because the cartilage that sits on top of them can go crazy and turn into chondrosarcoma. So this patient's got the syndrome called multiple hereditary exostoses, that, like everything, had a previous name. It used to be called diaphyseal just to confuse you. Yeah. So you can get them solitary by themselves, or you can get them as part of this syndrome. But these need imaging if they start to grow or if they become painful. After you reach, so they'll grow, so you see them in children, they'll grow as the child grows, but they shouldn't grow disproportionately to the child. So if they start growing and the patient is an adult, then that tells you that there's something wrong, like the cartilage is growing when it shouldn't. That tells you it's probably turned cancerous. So these are concerning if they grow past skeletal maturity. They have many different appearances, so quite often people can get confused by them. These are very typical. If you get other bone lesions and you're not sure, don't call it an osteochondroma, send it on. Back to something a bit easier. These become easy. 60-year-old woman with a lesion that's quite difficult to see because it's fairly subtle, but there's an abnormality of the proximal humerus and the humeral head, humeral neck. Definitely can't draw around it. The bone is moth-eaten and mottled. Maybe there's a fracture here, hard to say. So we're coming back to the easy things. 60-year-old woman with an aggressive bone lesion is metastasis or myeloma. So this is another myeloma, starts out as plasmacytoma. This solitary lesion is called a plasmacytoma.